Bismillah ar-Rahman ar-Rahim. Welcome in this usual new meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings, online CME. Today we are honored to have great moderator, Professor Ayman Rifai, and the great speaker, Professor Ahmed Elkeraie. Our moderator today is Professor Ayman Rifai, Professor of Nephrology and Medicine, Mansoura University, and in Mansoura Kidney and Urology Center, and the Vice President of Mansoura Kidney and Urology Center. Professor Ayman is the President-elect of Egyptian Society of Nephrology and Transplantation, and he is the Egyptian Society Renal Transplantation Chapter Chair. Professor Ahmed Elkeraie is Professor of Nephrology and Medicine in Alexandria University, one of ASMT board members, and the head of nephrology department in Alexandria University. We are honored to have him to speak about an important topic for all those who are going to manage kidney transplant, about the immunobiology of kidney transplantation, including HLA matching and cross-match, etc., and all immunological aspects. And we expect this topic to be held in two parts, and this will be, inshallah, the first part of it. I will leave the floor to Professor Ayman to lead this meeting and further introduce Professor Ahmed Elkeraie and highlight the important parts of this topic, and we'll start our meeting. Thank you. Please, Professor Ayman, start.
Thank you very much, Professor Yasser, for your kind introduction. I think, first of all, let me take this opportunity to thank and congratulate Professor Yasser Abdel Hamid for his excellent performance in maintaining and continuing the ESNT activities, actually with full dedication, seriousness, and sincerity. Thank you, Professor Yasser.
Thank you, Professor Ayman, for your kind words. Thank you for being with us, for your support.
Thank you. It's my pleasure, actually, to introduce Professor Ahmed Fathi Elkeraie, a dear friend and brother. Professor Elkeraie is Professor of Nephrology and is currently the head of Nephrology Department in Alexandria University. Actually, Professor Elkeraie is an eminent nephrologist with distinguished contributions, and maybe the most notable one is his great contribution in the ESNT guideline in management of glomerular diseases. Professor Elkeraie is going, as Professor Yasser said, tonight to address a very important topic in kidney transplantation, which is the immunobiology of HLA. And as we all know, that HLA matching is a cornerstone in the successful kidney transplantation. Because we believe that successful kidney transplantation depends on good preparation and optimal selection of the potential kidney donor. So the HLA matching and immunological stratification is a very important step to guarantee successful transplantation, better graft outcome and survival. Please, Professor Elkeraie, we are eager to hear from you a very updated presentation as usual. Please, Professor Elkeraie.
السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبده الله ورسوله. Thanks, dear brother Professor Ayman Rifai, for the very kind introduction. Thanks, dear brother Professor Yasser Abdel Hamid, for the continuous effort and the elaborating, dedicated effort, as Professor Ayman mentioned, for maintaining this work after our late Professor Hussein Shaisha, rahimahullah, and may all our deeds be in his, inshallah, mizan, and he would be pleased, inshallah, subhanahu wa ta'ala, that we are following his way of teaching others and transporting and transferring this science that we know to our younger colleagues to help people around the world. Without further ado, I would go to this very tough practical and laboratory subject. I will divide the talk, as Professor Yasser mentioned, into two parts. And as I did agree with Professor Ayman to make the first part only related to the HLA and eplet matching or epitope matching to understand this in a better way. And the next part, inshallah, would be with the cross-match and the PRA with the different methodologies and techniques for that part. To start with the HLA, we have to understand few points. The very important point to be understood is what is the importance of the HLA, absolutely, and what is the importance of the HLA typing relatively in the armamentarium of other factors related to successful transplantation, both on short and long-term outcome. That's why you might find that I'll be shuffling between some statistical and clinical data and some laboratory data from the other side. So please try to focus not to be lost from the way I'm going through. First, I will start by the current guidelines. And this is the KDIGO guidelines for 2018 for the kidney transplantation. And this is the immunological assessment chapter. And if you go through, you would find that the major part of the immunological assessment chapter and the major recommendation, this is the short listing of the recommendation, were all about the DSA and the PRA and the sensitization and the allocation according to the sensitization, to the extent that the HLA antibody measurement or the HLA typing measurement was mentioned as a mode to identify the HLA antibody rather than to identify the matched type. But please take note of the recommendation 19.1, which is communicate all sensitizing events to the HLA laboratory. All sensitizing events, including blood transfusion or blood product transfusion, even platelets and definitely plasma, pregnancy, miscarriage, or clinical events like PRA, previous or history, vaccination, withdrawal of immunosuppression, transplant, nephrectomy, significant infection even. So likewise, when we send our pathology to the lab, we should send the clinical data. Again, when we send for HLA typing or PRA typing, we should send for the clinical data as well. Then perform HLA antibody, and this part we will go through later on when we go through the PRA and the DSA and so forth. And then they recommended the frequent testing of HLA antibody, and they do not suggest the non-HLA antibody, but they do not as well suggest routinely testing for non-HLA antibody. And they suggest informing to the kidney transplant patients or potential recipients based on blood type and histocompatibility testing results. So if you find this might be the only glimpse to point that you need to have an HLA as well as the blood typing. And here we recommend offering kidney transplant with immunologically reduced access to transplant to a larger disease donor pool, kidney exchange program, or desensitization. That's to say, to avoid desensitization, make it the last choice, not the first choice. So the KDIGO did not mention that the need for HLA typing is for the absolute calculation of the match or the mismatch. It's further for the detection of the potential antibody. Please take very close note of this for what's coming later. Then we come to our own Egyptian guidelines. And this was a piece of art that was put all together by many of the superb professors in Egypt, starting from the late Professor Barsoum and Professor Shukair, along with Professor Ayman Rifai himself and a group of others. And it was distributed to many of us that we revised and answered some of the questions that was posted. And then the final version was, as you know, published in the Arab Journal of Urology. And if we come to the part of immunological risk assessment, you would find that this is a risk assessment. We strongly recommend the human leukocytic antigen typing of kidney transplant donor and recipients using molecular methods, preferably antibody titration method to remove inhibition. So we need to understand what are the methods of HLA typing and what is the difference between the molecular or the CDC methods. Typing should include all loci. Here, this is very important point, and this is a recommendation with the level of evidence D, including DQ, DP in sensitized recipients. So this might not be in everyone, might be better in everyone, but in sensitized recipient, you should have DQ and DP. We strongly recommend testing for anti-HLA antibody, which we'll come to later on. We strongly recommend the pre-transplant assessment of the recipient past and present immunological risk factor, including DSA, and the retransplant population. We recommend the high risk score of for historic DSA to repeat mismatch, especially at class 2. And now, for the second time now, we look for the match and the mismatch, especially at class 2. Then we recommend using the recipient immunological risk for individualization, and this will come in the next table, as you will see. And this table, although it's a very holistic table, including all the tools that we can use to assess the immunological risk, not only the HLA that we are talking about tonight, but we need to stress this point actually. This very nice table has categorized patients, as you can see, into 5 categories, from category A through to category E. And they consider category A is the highest risk that is contraindicated to receive a kidney transplant. And the category A is a patient with positive CDC cross-match, with a positive flow cytometry cross-match, with a mean channel shift more than 250, and the positive DSA with a relative intensity score of more than 17. So please remember these 3 things: positive CDC cross-match, positive flow cytometry cross-match with a mean channel shift of more than 250, and the positive DSA with a relative intensity score more than 17. This is contraindicated to receive a transplant in our guidelines in Egypt. The second category is category B. It's again a very high risk, and it requires desensitization. Whatever the method of desensitization you're using, a combination of the 2 or 3 tools, IVIG, plasmapheresis, anti-CD20, better off the optinumab, the long-acting one. Anyhow, how do you calculate this very high risk? It's by a positive, again, flow cytometry cross-match. Please note that it is not positive CDC cross-match here. It's only positive flow cytometry cross-match. And guess what? With the mean channel shift less than 250 or equal to, not more than 250. And the positive DSA relative intensity score less than 17, not more than or equal to 17, and the historic positive DSA. So a historic positive DSA is important. And please note the word DSA, which is the donor-specific antigen, although we're not going to elaborate again about this night, but we need to understand how to know and how to calculate DSA, and this implies to reading the HLA in the proper way. Category C is a high risk, not a very high risk, it's only high risk. It's possible for desensitization, so it's not a must, but induction is mandatory. Modified immunosuppression, so you have to use the higher level of immunosuppression, mostly the tacrolimus MMF combination, and follow-up protocol as well. Previous graft failure, so these are the determinants of these high risk. Previous graft failure due to rejection, not due to any cause, but due to immunological cause, a rejection. During first post-kidney transplant year, so it should be an early rejection, not a late one. A retransplant, so a patient who had been transplanted before. A full HLA mismatches, and this is a very important point. So a patient with a full HLA mismatches with a zero match is considered transplantable in Egypt, although it's a high risk, but it's considered transplantable. A CPRA of more than 80% positive, non-DSA anti-HLA antibodies. This is a very important. More than 80% positivity of the calculated pan-reactive antibody, but these positivity are non-DSA. Again, you have to understand what is the tissue typing of your patient to better interpret the antibodies that he has. And you need to know the specific and the detailed tissue typing of the potential donor to find out whether your potential recipient has a specific DSA or he has non-specific DSA as an anti-HLA antibody. We'll come to understand this later on, but I really prefer to start with the guidelines and then to try to clarify it. Intermediate risk, which is category D, is a patient should receive induction, but it's not a mandatory, and he should receive a modified immunosuppression and follow-up. And this is a retransplant patient, an HLA greater than 3/6 mismatches, a CPRA of 20 to 80%, again, of non-DSA anti-HLA antibodies. So again, note that here a full mismatch is considered category C, and more than 3/6 mismatches, that's to say only 2 antigen match, is considered category D. A low risk is lacking all of the above factors proportionate to HLA matching and without anti-HLA antibody. So a low risk by definition is a person who is having a match 3/6 or more and having no specific donor antibodies or no donor specific antibodies. So these are the 4 categories. I would like just to elaborate more about the relative intensity score. How is it calculated? It is calculated from the relative mean fluorescence intensity or relative MFI. If you have an MFI of more than 10,000, you give this 10. Of more than 5,000 till 10,000, you give this 5. Of more than 2,000 MFI till 5,000, you give this 2. So if you have a 3 antibodies that are DSA antibodies, not any antibodies, not any HLA antibody, a donor-specific antibody. That's to say, the donor has an HLA B27, and the recipient has antibodies to B27. If this mean fluorescence intensity of the B27 antibodies is more than 10,000 MFI, you would give a score of 10 for this antibody. If he has another one that is specific for his donor, that of 5,000 intensity, you would give a score of 5. A score of 2,000 MFI, you would give a score of 2. So 10 plus 5 plus 2 equals 17. So if the patient has a relative intensity score of more or equal to 17, this is considered contraindication absolute for transplantation. You should remember this should be donor-specific antigen. That is the one that counts. So with this introduction for the guidelines, let's go to understand what is the major histocompatibility complex, and what is the HLA, and what is the methodologies of typing, and how we should read the HLA to interpret whether this is a donor-specific or non-donor-specific, and what is the further advancement in this point, what is the HLA matchmaker, what is the epitope match or the applet or the triplet match, and how can they help in better outcome for our transplant population. First, HLA or MHC, which is the major histocompatibility complex, is a set of genes that encodes 4 proteins that regulate the immune response. So after all, there are genes on chromosome number 6, as you all know, short arm, and these gives out proteins that are readed in alleles, and these gives you out or the numbers. These are the alleles, and these are the numbers, and this give you a specific immune response. Class 1 and 2 encode for cell surface protein, and class 3 encode for complement protein. So there is class 3 MHC, but it is related to the complement more than it encodes for the cell surface protein. The HLA is a part of the MHC, but it is found on the chromosome 6, as we mentioned, and it is important for self-recognition and hence identification of a foreign antigen like microorganisms and others. And this is class 1, and that is class 2. Class 1 is found on all surfaces of nucleated cells and the platelets as well, although platelets are not a nucleated cell. So platelet can help in transfusing the class 1, and thus can be a cause of sensitization for a patient if he received platelet. Plasma should not be a source if it is totally deprived of cells, but this is not the case in most of the cases. Plasma it's not ultra pure of all types of cells, and the load of the leukocytes in the plasma can be a sensitizing event for this patient. And this is a note that should be take noted of when you do a desensitization for a patient by plasmapheresis. It might not be the best thing to do it with plasma, because in this situation, you might be introducing new antigenicity to the patient. Definitely not like if you transfuse blood, but you might do so. So it could be done with albumin better. So it presents the class 1 present these cells to CD8 positive cytotoxic cells. It is HLA A, B, and C. So class 1 is A, B, and C. And these recognize the cells which have been infected by viruses, bacteria, parasites, and tumor. So the surveillance for class 1 actually is a little bit more wider than class 2. And this is the structure of class 1 with the alpha 1, alpha 2, alpha 3, and the beta microglobulin that through which they attach to the effector cells. Class 2, on the other hand, is found only on the cell surface of antigen-presenting cells, dendritic cells. You're not following the sound? Can you hear me?
Yes,
It's okay now.
clear,
It's
it's
okay
clear.
now.
Okay. Okay. So, they are found on the cell surface of dendritic cells, Langerhans cells, activated macrophages, B cells, and thymic epithelial cells. They are antigen. The antigen recognition occur by T helper cells, which is the CD4, not the CD cytotoxic cells like the CD8 and they recognize cells that have been infected by bacteria or parasites, or some injected proteins. Class 2 is not DRB1 or DRB3 like we think, and that's it. And this is a very important point to emphasize. You would find in the detailed data of the guidelines or the clarifying rationale of the guidelines that you should test for the DQ and DB, not only, and DR, B1, B3, B4, and B5 loci. It's not only the DR, B1, and that's it. We have to be, because data are accumulating that these, specifically DQ, and in the sensitized patient DP, you need to know whether the patient has an antibody. Again, I'm overemphasizing that the main cause of doing the HLA typing nowadays is not to look for the match or the mismatch. It's further to look for the preformed antibody to the donor specific antigens, which could be against DQ or DP, not only to the DRB1. So you need to do the typing of the DR, the DQ, and the DB. The DR has 1 alpha chain and the 4 beta chain. Hence, it is called DRB1, B3, B4, and B5, according to the beta chain number. The DQ has an alpha chain for DQA1 and the beta chain for DQB1. And the DP has an alpha chain for the DQP1 and a beta chain for the DPB1. I'm sorry, this is DBP1. So this is how we read the HLA result which come back from the lab. And we'll stop here for a while. So this is the HLA, which is the allele. This is A, which is the gene. And you know that the alleles are 2 alleles. One comes from the mother and one comes from the father. And the gene, we know now that we have at least 6 genes. We have A, B, C, DR with the different loci, and DP and DQ. So we can have HLA A, we can have HLA B, we can have HLA C, we can have HLA DR, we can have HLA DQ or HLA DP. And for the DR, you can have it DRB1, DRB3, DRB4, or DRB5. Then you have this, the hyphen is here to separate the allele from the gene. And this, the asterisk is just a separator. And now we have the first set of 2 numbers. This set of 2 numbers is the allele group, which we call it the antigenic group. This is the low level of typing. Like if you say the patient blood group is A or B, for example. This one is, if you say the patient antigenic type for the A02 or 07 or whatever. So this is the type, the antigenic type of that gene. This is the protein that is excreted by that gene. But This is a wider group by a low resolution. You can have it by a higher resolution, and the higher resolution, you have here this semicolon as a field separator, and then this O1 is a more specific allele, which you can tell that O2 can be O2 dots O1 or O2 semicolon O2. So you have two alternatives for this allele group. Both can be with the same allele group number. Then you have another field separator, and you have another protein silent mutation with coding sequence, and another non-coding region, and then you have what's called the suffix or the sequencing at the end, and likely that all these parts are not in active role in reading our tissue typing for transplantation so far. So this is a considered low resolution, and this is considered a high resolution. This is called a 2-digit HLA typing at a molecular at a antigenic level, and this is called a 4-digit HLA typing at a molecular level. Now we can understand this B is the gene locus, this is the allele group, and this is specific HLA protein. And as we mentioned, those are not important so far. So this is the low resolution typing, and this is the high resolution typing, and this is a full sequence typing for a genetic material, which might prove later on to be important. And the major problem with the HLA that we now have more than 15,000 HLA molecule identified, and you can never memorize these, and they are nomenclated after the serial of their identification. That's why you don't have the A from 1 to 100, for example, and the B from 101 to 200, and the DR from 200 to 300. Unfortunately, it's not like this. Whenever they identify a protein or an allele or a gene, they just go and put it with the next number to come. That's why it's very difficult in the nomenclature, and it's very difficult to memorize these. Look here, the allele here is B15, and B15O1, the antigen name is B62. B15 again, which is the same allele, but another protein, it's O2, the antigen name is B75. B15 with a protein O7 would be B62 as well, although this is 1562 and this is 1562, although the protein here is different. So this is a full match, although the protein is different. This is O1 and this is O7, while this is the same allele group, but is not, the protein is different from the O1 and the O7. Why this point? Please wait to understand that why different alleles or proteins can give the same antigenic name. The same goes with C and the DQP1, DQB1, either O3O1 or O3O2. You don't have a lot of permutations and combinations with the DQB1. It's either there or not there, and the number of alternatives are not too much, so you don't have a lot of DQ actually, neither a DP as well. The initial way for detecting those molecules and their antigenicity was the complement-dependent lymphotoxicity, or the CDC, which was called the serology. And to that level, you cannot detect the high resolution. It was only the low resolution. Then with the DNA based starts to have the high resolution. So this is O2, it was only A2, and the A2 on the external surface, just antibody binding site by the epitope by serology, by CDC technique or complement direct cytotoxicity. But when you go inside by the PCR to the nucleotide sequence and you read the protein that is excreted by this specific allele group, you can go to the lower level, to the higher level of resolution to understand that this O2 can be O2O1 or O2O3. And these are not likely the same. It's exactly like that we now know that an A blood group is not only A. There is A1 and A2. And it's not probably the same condition if you transfuse A2 to A1, so which was previously known as A and that's it. It's something like that. The higher level of resolution that can be used or that is now in current use for identification of the HLA types by higher resolution are the SSO and the SSP, the sequence-specific oligomer, and this entails the Luminex and Fleximap, and these are techniques that is flow cytometry based, depending on number of beads that is present, and it reads the different beads that reacted and that does not react with the that did not react with the patient blood, and hence it can identify the patient type in a very specific way, and it can be rapid, and it can run, as you can see, like 1,044 or 144,000 tests per hour. And this is the SSP as well, which is another type of the sequence oligomer. Now, let's have just an icebreaker with a couple of questions. And I wouldn't be eager to hear direct answers right now, but please put your answers in your mind and try to find out with the rest of the lecture whether you answer these in a right way or not. So the first question is, which of the following is true regarding long-term allograft survival? Okay, so now we are asking about long-term allograft survival. First, class 2 HLA mismatch is associated with antibody-mediated rejection. Is that true? If you have a class 2 is the DR, DQ, and DB. Is class 2 HLA mismatch associated with antibody-mediated rejection? Next option, patients who are matched for HLA-DR will always be matched for HLA-DQ. Is that always, or almost, or never? And what is the meaning of a linkage disequilibrium between those two alleles? A median allograft survival for a zero mismatch transplant is 15 years. So allograft survival for a zero mismatch, that's to say a full match, a median survival is 15 years. Zero mismatch diseased donors do not reject. Is that right or wrong? And is it the same with the zero mismatch of diseased or versus living related donation? If the mismatch is between living related versus diseased, is almost always unrelated. It is the same regarding the of rejection between them or not. And this is another question, an MCQ one. Choose the transplant with the best expected allograft survival. And this is actually a mathematical quiz, because there are many options that are combined together to try to get the best out of it. So choose the best transplant with the best expected allograft survival. A living donor from a 60 years old grandmother who is a 4 HLA match. So she's 60-year living donor and there are 4 HLA mismatches. Or a living donor from a 30 years old father to his son who is 3 HLA mismatches. So the donor is 30 years, again a live-related, and the mismatch is 3. Or a deceased donor from a 30 years old, 3 HLA mismatch. So like the above, like number B, but is a disease, not a live-related, and who died from a road traffic accident. And the last option is a deceased donor from a 50 years old, 1 HLA mismatch, that's to say 5 antigen match, who was hypertensive and died of a cerebral or a cerebrovascular accident. So as you see, it's a brainstorming quiz, because obviously, as we will see in the next few slides, it is not one factor. And what I want to highlight that you should never take the immunobiology for donor as the single to accept or reject a donation. And let's go through the data. Let's first look for the lessons from the registries of how much the HLA match or mismatch weighs, and how and where does it rank in the importance of the acceptability of the donation. The HLA has been at the forefront for a while, and this is simply like the parachute trial. It has never been done in a controlled trial that you look for a group and another group without a match, or with perfect match and with poor match, and you compare them in a random way. It never happened, and it will never happen, as you understand. The evidence behind HLA matching the macro level population studies from national and multinational registries. So the importance comes from the registries with the big numbers like NZ, ANZD data, for example, UNUS, USRDS, and so on, the opt-in and others. Most national registries mandate data collection, although it is difficult to compare the results due to different patient population and healthcare symptoms and data collection method. So you cannot compare between apple and oranges. The system in the Gulf is different from that in the States, it's different from that in Australia and New Zealand, and so on. So you cannot simply pool them together and compare everyone to other. But on any account, you have major numbers within many of these registries. And this table summarizes the lessons from the registries. And I will focus on the main results. Just these are the author registry and the years and the numbers of patients, as you can see, 2,000 patients, 9,000 patients. The years of follow-up are more like 10 years and more. And here, 9,000 patients, the year of follow-up, like 11 years, 15 years for 3,000 patients, so on. And the research question, here the research question is HLA-DR mismatch and donor age are as important as or not? Is HLA mismatch and donor age is as important as, which is the most important determinant? Here the DR specifically, and here the whole HLA. Relative importance of HLA mismatch and donor age, though the main comparator is the HLA in relation to the donor age in those three studies. Here, the main comparator is HLA in relation to all other factors. Here is the donor and recipient age mainly, and here is the mismatch and so on and so forth. And these are the other types of parameters that were used to find out if they can potentially affect the outcome of the patient. For example, A is the donor age, B is the HLA mismatch, C is the recipient demographic, including age, sex, and race altogether, D is the primary renal disease, E is the donor demographic, including the race, and I is the variable that is addressed, and F is the transplant era or year, and G is the cold ischemia time if a disease donation, and H is the panel reactive antibody, and so on and so forth, as you can see. And look for the results. Allograft survival at 5 years was similar for HLA-DR mismatches. Donor more than 35 years of age had worse survival. So here, the donor age more than 35 is a determinant more than the HLA-DR mismatch. Survival rates were similar for donors up until the age of 49. HLA mismatches increases risk of graft failure in hierarchical manner, and this effect persisted and with modern immunosuppression. PTLD is associated with 2 HLA-DR mismatches. So if you have a 2 HLA-DR mismatch, that means that you're giving higher immunosuppression potency, and this precipitates to occurrence of PTLD. And even with the modern immunosuppression, HLA persisted as a valuable cause for the loss of the graft on the long term, or increases the risk of graft failure. Here, HLA mismatches and donor age associated with disease donor survival. Advantages of younger donor, less than 35, offset poor HLA mismatch. That's why these are very specific points. If the donor is young, like 25 years or 30 years, you probably might neglect a higher level of mismatch, because the donor age below 35 is more important than the degree of mismatch between the donor and recipient. And these are data from the registries through years of follow-up and thousands of patients. If we go down through all this, which we will not do because of the time constraint, you would find the proper answers for the MCQ, the previous one. So you would choose the father who is 30 years old with 3 mismatch to be much better than a diseased donor who had only 1 mismatch, or even another live-related donor who only have, for example, 1 or 2 mismatch, but he is 45 years old instead of being 30 or less. And this is the kidney donor quality. And again, this combines the mismatch in number and the donor age less than 35 trajectories, 35 to 44, more than 45, and then the mismatch of 2 to 3 instead of 0 to 1 with less than 35, 35 to 44, or more than 50. And the reference is the 4 to 6 mismatches with the donor less than 35. This is the reference that they considered the one. And the hazard ratio, according to the confidence interval here, and you can see the level of confidence interval, how wide between different sets. The donor with the lowest mismatches and the age below 35 had the best outcome. Hazard ratio is 20% less than the reference. Go to the highest mismatch with the high age, this is the worst outcome. The 50% increase in the hazard ratio, lose the graft within 15 years, as you can see. And that's why the common between HLA class 1 and class a further added step. Is it the same? Is HLA class 2 more important? And is it specific for the DR or not? Actually, many randomized control trials showed that the antibody-mediated rejection is more prevalent with the HLA class 2 antibody, and in particular, the DQ, and hence we should HLA class 2 derive the antibody-mediated rejection. By why it's a worse outcome, there might be a overlap between class 1 and class 2 that is inherent to methodological limitation, which cannot be taken into account for. On many occasions, HLA-DR is matched and HLA-DQ because of linkage disequilibrium, as we mentioned earlier. But this is not a rule of thumb. This, although it occurs in many occasions, but it can happen that they are DR match and DQ mismatch. DQ and DB molecule alpha and beta chain, as we mentioned, and they can exist in cis or others. And it has been shown that DQ mismatch increase the likelihood of acute rejection, antibody-mediated rejection in the ANZ data. However, the DQ mismatch alone was not a risk factor for allograft loss, but the combination of both DR and DQ mismatch had the worst outcome. So this is a very important point of how to interpret the mismatch per se. And here is the mismatch, not the preformed antibody, not the DSA, which is another issue that we will come to next time, inshallah. Again, just to understand the clinical value of the HLA and not to overestimate and not to underestimate. The SHARE 35 initiative for kidney allocation policy in the States was implemented like 20 years back. And it gives absolute priority for donors under 35 years of age to be allocated to younger recipients regardless of their HLA matching. This is the important message that was taken from the previous slide, that after the Grich study that showed that donors with the age of 35 or less are much more likely to give a longevity for the graft and a better survival, they started to overlook the match level or the mismatch level in the HLA for those donors in particular. In particular, if the graft is going for a younger recipient, because they would like that the graft would live longer so that the patient might not need to have a second transplant in his further life. They concluded that the good quality donor outweighs the benefit of HLA matching, and this had been there for 20 years in the States. Donor age alone does not fully capture information about donor quality. So it is donor quality, the age is important, but you have to look for other variables, specifically if it is a diseased donor, like the ECD. Deceased donor is ECD or a DBD, and if he is dying from a cerebrovascular stroke, for example, or other causes, this might offset the good potential effect of the donor age. That's why it was calculated as the kidney donor profile index. And the kidney donor profile index does not take into account the HLA match at all. When you look for the kidney donor profile index, there are 10 factors. The HLA is not present among them, but they give additional points for a full match. So if the kidney donor profile index, whatever value it is, and you have a zero mismatch, that's to say 6/6 or 10/10 matches, you would add a number of points to the kidney donor profile index to increase the score. And again, they give it to a DR match. If you have a full DR match, because the DR is considered stronger in the match than the B, and the B is stronger than the A. That's why we interpret the match as in the British way in 0, 1, 2, for example, or the mismatch, instead of saying a total of 3 out of 6 mismatches. And this is the expanded criteria donor versus the kidney donor index. And you can see here expanded criteria only takes in consideration whether the age is more than 60 or the age is 50 to 59, and it calculates whether he had a cerebrovascular stroke, the creatinine, how much, and the creatinine with the stroke and with the hypertension and so forth. But here, this kidney donor criteria index, as you can see, it takes in consideration the age with a specific hazard ratio, the height, the weight, the race, he have a hypertension or not, diabetes, CVA, creatinine, HCV positive or not, is it DCD or not. This is all for disease donation, not for liver-related or liver-related donation. And as we mentioned, this KDRI does not involve HLA at all in the score. But if the HLA is totally matched, they give additional point. And if the DR is totally matched, they give additional point, even less point, even if the other are not matched. So does HLA match differs between diseased and living donation? Actually, yes. Renal allograft survival is improved, definitely with the living donation over the diseased. There are similar outcomes that thrive between the older, but a well-matched, and by well-matched, we mean a haplotype match at least, يعني the 0 to 3 mismatch. Older live-related donation have better allograft survival than a poorly matched younger deceased donation. Although the age is more important, but if it comes from a living and better match, this is better than a mismatch from a diseased donor. Now, factors are getting more complex, but you have to calculate, especially if we are going to move to the era of disease donation, we have to have better calculation. What are the best choice for our patients? In most recent UNIS analysis, live donation with 4 to 6 mismatch lost their live donation advantage and had similar allograft survival for 0 to 3 mismatches of diseased donation. So if the mismatch is higher, now it can compensate for with the disease donation if the mismatch is lower. Comparing with a more selective group, 0 to 1 mismatch of disease donation, poorly matched 4 to 6 mismatch had worse allograft survival. Definitely, this in this specific situation, it counts. So the data of the HLA typing, absolutely, without the look for the PRA or the donor-specific antigen, should not be taken as an absolute indication or contraindication for transplantation. It should be put as a piece of the puzzle in the holistic picture that includes, above all, the donor age, specifically if young, live-related donor, and other factors to be taken in consideration. And this is the graph that shows what we were just saying, the live-related with a low mismatch and the disease donation with almost absent mismatch are similar. But if you have a high mismatch with live donation, you are even worse than the disease donation with the full or very minimal mismatch. Does it affect the long term or the short term? There is no defining predictors for the long-term survival, although those patients tended to have better HLA matching, younger donors, and live donation. So you cannot rely on the HLA only as a cause of better survival on the long term. Live donation and younger donors, as well as HLA match, are all together causes better survival. Again, we know that 50% of the graft had been lost from chronic immune injury, which might be, after all, related to the mismatch. So it should be taken into consideration. Now, knowing that HLA is that much important, more important first for the detection of the antibody that can cause major troubles in the short term before the long term. And second, to identify the degree of match to predict the survival of the graft, specifically if the patient who is donating the kidney is a deceased donor or is an older donor, more than 35 or even more than 50 years of age. Do we get, or can we get to a better tool more than the high resolution that we've just mentioned? Yes, we can. We can go for the applet matching or the epitope matching. And just to cut a long story short, because I know that we are running out of time. What is applet and what is epitope matching? The next coming slides and cartoons might explain this. This is how it was discovered from the very early first discovery of the histocompatibility in mice down to the HLA alleles that were more than 15,000 5 years back, including the many molecular and immunological assays that have been developed. These developed the antigen that was understood and we just elaborated upon earlier. Then the epitope. The epitope is the antigenic determinant in which the site on the surface of the antigen molecule to which a single antibody molecule binds. So the epitope is the exposed part of the antigen that is actually active in the antigen-antibody interaction. It's exactly Like if you say that you have a key, and the key have a main part that you hold and a shaft, but these are non-functioning. The functioning part are the tooth of the or the teeth of the key that unlock the door. So the epitopes are those teeth that are exposed upon the surface of the antigen. And even so, those epitopes, there are applets. And the applets are small configuration of polymorphic amino acid residues on the HLA molecule. And these applets are usually three. Classically, the triplets are three amino acid sequence, and the applets are some sort of 3 amino acid sequence or more that come in a 3 angstrom area, and these pattern of presentation causes the epitope that become antigenic. I know it's a little bit difficult, but the next photos would simplify things. This is the antigen, which is the HLA antigen, whatever it is, HLA-B44. And the antigen has 4 arms. Each arm has an antigen binding sites. So it can bind to 4 antibodies. And for each one of these antibody, the antibody has an exposed epitope that can fit into specific antibody. So these are the epitopes with the different confrontational background, and as you can see, this is actually is not just an amino acid sequence, it's an amino acid sequence with a physical or a monomeric or a multimeric structure. So the structure, as well as the physical structure, as well as the chemical structure, does affect the antigenicity of these specific epitopes. So anti-HLA antibody do not recognize the whole antigen. In fact, some part of the antigen that are different from the self, and these are called applets. And the applets, the antibodies, are directed to either to one or many applets, and the many applets are called epitopes, and these can be linear or discontinuum applets causing these epitopes. Again, this is a multivalent antigen with different types of antibody that can react with according to the different shapes of the epitopes that can be presented. And this is a multivalent antigen, but with a repeat epitope. All of these, and of course, just an antigen would be much less antigenic than a one like this with different antibodies that can react with. And the epitopes can be linear. Here it reacts to in the chain of the protein, just 3 or triplet, which is 3 amino acid residue, directly linear epitope. But here it can react to this continuous amino acid, which is discontinuous epitope, not a linear one, on the outer surface of a folded protein like this, for example. So this is the main difference between the triplets and the applets. And the applet can be on the outer surface of a folded protein like this, and the whole area of the applet should be in a radius of a 3 angstrom, and that's why it can be caught by a single antibody with different arms of the antibody to recognize those different applets. And this is an example for a hexamer with 6 applets on the surface. One of them, which is the H3 one, is a specific determining antibody specificity. And the other 5, the L1, L2, L3, and H2 and H1, all of them are just what they call a CDR which determine the affinity, but not the specificity to the molecule. And this is the complementarity deterring region, or the CDR. And this is an example of a topography for an HLA-DR and HLA-DQ molecule. As we mentioned early, the linkage, this equilibrium between them. Look here, the B1 is more or less similar to the B1 here. And the alpha 1 here might be a little bit similar here, and the alpha 2 similar to this one, and the B2 a little bit similar to this one, although the whole molecule is not like the whole molecule, but the outer surface that is exposed to the action of antibodies is more or less similar. That's why the linkage equilibrium between the HLA-DQ and the HLA-DR is there, because the epitopes are more or less the same in most of them. Of course, the number, we've just mentioned that you have more than 15,000 HLA antigen identified or protein. Now, how many applets you can think of? A single antigen or protein can give you as much as 9 or 12 or 16 applets. So definitely you will never be able to do applet-based mismatch according to a typing that you are waiting to come out from the lab reports. So this needs the HLA matchmaker, which is the software program that uses the different type of applets that have been typed and do the virtual matching between, not the virtual cross match, but the virtual match and mismatch based on the applet or epitope, based on the epitope registry that is already there. What's meant by that? They do not do really type for the epitope. They still type for the HLA antigen and the protein, the allele and the protein, and they know the physical chemical structure of each of these. So based on that, they put the epitope and they look for the private and the public shared epitopes. And this is the CREGs, or the epitope that is shared and cross-reacting antigens, versus the private antigen that does not react with other public epitope. It only reacts with its specific epitope, not any other one. So these are structurally based matching with the HLA matchmaker. Now we have the newest versions, even more than that. And this is the report that you can get out from a 4-digit HLA typing data. Definitely, you can look for the mismatch based on the epitope. Although here, for example, the patient HLA and the donor HLA looks that they are here B111 and 0405, but they have 11 mismatch on the epitope level. Here 1302 and 1119, but it's only one mismatch on the epitope level. So this is an excellent, although it's totally different antigens and alleles, but it's excellent match here. When you have a match like 4 to 6 is excellent, 6 to 9 and 9 to 16. This is how you categorize the applet match level. And of course, you will have to have this out of the matchmaker. And many studies have shown that when you have the HLA, DR, and DQ based on the applet mismatch, you might have a better graft survival than if you have it on a higher level of epitope mismatch. Here, for example, 0 to 9, and here is 10 to 57. Here you have significant statistical difference in the survival over 10 years, and the same is for the DQ as well. I hope that I have shown you that HLA, of course, I did not went into the specific technical laboratory techniques for how to test for the HLA, because this is not our own subject. It's more related to our immunologists in the lab. We have to cooperate with them. We have to send them the full data to get the full report. The match alone or the mismatch alone is not the most important question. The most important question is the antibody presence to your specific HLA in the donor, whether the recipient has a donor-specific antibodies or not. The match should be thorough and complete with a high resolution molecular SSO or SSP way, and not only serological, and it should entail the DQ, the DB, and the DR with the whole beta chains 1, 3, 4, and 5. And the weight of the match or the mismatch alone is not the proper way to categorize the donor trajectories. It should be in the context of the other data of the donor. Thanks for your patience, and I hope that you can have any questions, and I'll be able to answer, inshallah.
Thank you very much, Professor Ahmed. I really enjoyed your presentation. Actually, it's very interesting and updated, full, very rich and full of a lot of information. Actually, they were provided in a very smart way. And let me entitle your presentation as HLA matching made easy.
جزاكم الله خير. Thanks a lot.
الله يخليك. You took us on a journey from basics to advanced, and I just want to highlight a very important point that you addressed in your presentation, that although the HLA matching is very important, yet it is not the sole factor that govern the success and the outcome of transplantation out of other factors. The most important is the donor quality, the donor agent source, as you mentioned, and the kidney donor profile index is very important. I think the traditional approach of assessing the immunological risk in our patients based on the mismatch of HLA, whether A, B, or DRB1, it should be considered a crude simplification of the alloantigen exposure and recognition. So, as you mentioned, that epitope-based HLA matching, which become a new concept in clinical transplant setting, and that rely, as you mentioned, on the HLA typing on the allele level, and can be used to identify both the acceptable mismatch in sensitized patients and develop a mismatch strategy for the non-sensitized patients. Also the tissue timing is not a matter of HLA match. It's as you mentioned, it's the antibody detection. Especially we are in an era of increased recognition of the humoral immune response, which is a major determinant of the long-term transplant outcome. But I think we should, during the preparation of our patient, that we should, the antibody is a dynamic process. The formation antibody should be performed more than once. It should be repeated during the whole preparation period of our transplant couple. Thank you very much, Professor Ahmed. You simplified things and give us a lot of informations that govern the transplant outcome rather than the simple HLA matching. Another point that we should stress that DQ and DB, which is preferable to be done in all patients, but it is mandatory in sensitized patients. Thank you very much. I really enjoyed it, and I
Thanks, Professor Ayman. I come to notice now in the question that Professor Ahmed Mustafa is with us.
Yes,
And
we
of
need
course,
to. Yes,
he's the person to speak. If I know from the start that he is here, I wouldn't have spoken about HLA typing. So I would like to hear his input if he's still there.
Yes.
Excuse me, Professor Ayman and Professor Ahmed, to ask a question before the comment.
Yes.
And the question is really for Dr. Ayman for the last part of his comment. You recommended to follow up or to do antibody panel or HA panel, HL panel frequently during preparation of transplant couple. So how much do you recommend this, and when do you recommend this repetition of this antibody match or the pattern in the view, especially in the view of the limited resources, Professor Ayman? So can you give us a clear recommendation?
Yes, this is
indicated
very
to repeat, and when and how much is frequent?
Okay, please, Dr. Ayman, just give him a teasing answer that would let Dr. Yasser wait for the next couple of weeks, because as we have our settlement that we're going to come to this part,
discuss
inshallah,
this in details.
In part 2. But,
yes,
but
just
give him a seasoning or a flavoring answer to wait.
Yes.
I am speaking about the usual transplant, not the high-risk transplant of people.
Yeah.
Okay.
Yes.
Okay.
Because it's traditionally it depends on the period of preparation, Professor Yasser. It depends. If we have a long time, sometimes we may take a year of different donors and preparation. So we have to repeat it at least 3 times during this year, and at least within the last 2 to 3 months prior to transplantation. Sometimes it is performed once in the first visit, and that's it. I mean, it's like the final cross match with the flu or CDC. I think we should have DSA and PRA prior to transplantation. So I think, okay.
Yes, definitely, yes, Professor Ayman. And the other thing, Dr. Yasser, is it was stated in the explanatory part of the guideline that whenever you have a sensitizing event, you should repeat the PRA 2 weeks after. For example, if you have a mother give birth, or a blood transfusion or a platelet transfusion or a severe infection even, you should have within 2 weeks from the occasion another PRA.
Yes.
This is the state with PRA, and totally agree with you. But my question for Dr. Ayman about HLA. Do you recommend repetition of HLA at certain points?
No, definitely.
No. This HLA, like the blood group, I mean, this is not changeable. The changeable is the antibody formation.
So it's okay. This is clear. This is the clear message. Thank you. Professor
Ahmed
Said.
Mustafa? Okay.
He is not. Yes, he is with us. Okay, Dr. Ahmed Mustafa. Unmute yourself, please.
Assalamu alaikum. Sorry, I was like in the middle of a phone call. Sorry, I just heard my name. I was just distracted for a bit. Sorry.
I was just saying, Professor Ahmed, that if I knew from the very early start that you are here, I would handle you the microphone to give the lecture, because you are the one for the lecture.
No, I actually listened to your lecture. You did an awesome, wonderful job. Like I feel like there is no comparison, that I cannot compete with you anymore.
No, of course
you are
not.
The
this
prof.
Is thank you, Professor Ahmed. Thank you.
Okay, so what's the question?
We were just asking about. I was just trying to give a message that HLA typing is not, nowadays is not mainly to calculate the mismatch, because this might come at a next level of importance. It is mainly to calculate the DSA. This is the most important point. Do you agree with this notion?
Well, I think it's like both of them are important to my understanding, both mismatch and antibody, because like no one can argue if you have a zero mismatch, they have the better outcome. Because like, for example, identical siblings, they will have we like in our center here, identical twin siblings, we don't do even antibodies to them because there is no way. So I think it's both. Like you still need, like if there are zero mismatch, they have the best outcome. Less mismatch of for sure they have the best outcome. But I don't think you or at least in our center, we don't prefer people who has less mismatch over antibodies, because the antibodies play an important role. You cannot put an incompatible donor or an incompatible patient and donor together because they will reject instantly. I think both of them have an important role. Maybe mismatch is a little bit less now because of the advancement of our immunosuppressive. Maybe in the past it was because before development of the tacrolimus and all this advanced immunosuppressive. But I think it's the most important now is the compatibility between donor and patient is regarding to avoid donor-specific antibodies.
Okay, coming to this point, I've just had a case that is very interesting. I'd like to share your opinion about. I had a mother who is donating to her daughter, and it happened that they are full match, and they are full match in the whole set, including the DQ and the DP. Full antigen match, a mother, not siblings, a mother and a daughter. Okay. And the match is even weird to the point that they are a single haplotype, like that. For example, I mean, it's DR44, B4444, both the mother and the daughter. Okay. Yes. And the daughter has a PRA, which definitely is not a DSA, but just a PRA of 39% in class 1 and maybe 67% in class 2. In our policy, we transplant those patients without the PRA part, with no induction, with no steroids. And even we cut down the CNI over time to have them only on MMF. But in case of the PRA, although it is not a DSA, how would you consider the immunological risk of these patients?
Zero. No standard.
Okay, that's very good. That's very good, because I've been asking with the committee in our hospital about that. So no, you would consider this zero.
So this is actually, this is still considered standard risk. Like the table that you presented, I think it was the second slide, that table which has like A, B, C, D.
Yes, D and E, yes.
I think this table has to be modified a little bit. I think it's only 3 categories: high risk, medium risk, and then there is nothing called low risk anymore. It's called standard risk. So I think like maybe item A and B are still high risk. And then B and then C, D are intermediate risk, and then you have the standard risk. So standard risk mean that exactly as this case that you presented, there is no DSA. They are actually like identical matching, so there is no way that they will develop antibodies against each other. At least at the antigen level, they might be different at the allele level. But this case is considered a straightforward standard risk for kidney transplant. No need to do any desensitization. The PRA is against something else, is not against the current transplant. So I don't see that this is considered even medium risk or anything like this. Like PRA, like we don't look at the PRA, we look at the donor-specific antibody.
Yes,
because
this is important.
we transplant people who are like 80% PRA, but there is no donor-specific antibody.
Okay.
But I think,
That's very-
Professor Ahmed, that this case should receive induction and should be maintained on a steroid-based regimen.
Because of her antibody
Yeah.
level,
Still,
general antibody level.
yes, I think she should have induction and not offer the steroid-free regimen. She should be on steroids.
Yes, yeah, I think yes, because of the PRA level, yes, she is at a higher level of immunological risk than, of course, the fully or the zero mismatch if
Yes.
they have no PRA. Yes.
Some may argue about thymo induction rather than
Yes,
basiliximab.
Yes.
So my question is why you are panicked about the other antibody that are not relevant to the kidney? Just like this is my question.
It might be because of the if the patient has the ability to produce antibody, although this is not a specific antibody to the donor, because of course it wouldn't be a self antibody, but if the patient has this sensitized state in general, she might have some sort of hyperactive immune system. That might denote something like, for example, it could have a non-HLA antibody, for example. So you wouldn't take that as very easy way.
Okay,
I'm not.
This
I'm
my
not sure.
next question. Did you try to, or not try? Like, have you seen any patient who has been previously sensitized and become worse than who has not been previously sensitized in regard duration of the transplant?
I have one accident with a patient who was transplanted from a brother that was full matched, and we were very pleased, and even we were minimizing the immunosuppression, and he had a nasty antibody-mediated rejection that was proven to be non-HLA. He had a cross-match, post-transplant, full cross-match, physical cross-match with his donor, and he had the PRA, and both was negative. But it was antibody-mediated rejection with C4D positivity, with the absence of DSA, with the whole set of the pathology, and it turned out to be non-HLA antibody.
Okay, yeah, okay, yeah. This is something else, and yeah, this is something else. So is that what worrying you, that the developing of non-HLA antibodies, not the HLA antibodies? Is that?
Yeah. I was just saying that having this active immune system with the production of the PRA of 70 and 40% might be, although I'm not aware of literature about that, but might be an indicator that she might be at more risk of having any other type of immunogenicity, like, for example, non-HLA. So it's better off to be kept on the higher level of immunosuppression, not the lower one.
Okay.
This is a repeated scenario, Professor Ahmed. It is not guaranteed that we have a better match or a full match to have a better outcome. Sometimes the scenario is like you said, and mostly due to non-HLA antibodies. So this is a repeated scenario that we have seen.
Yes, although
times.
Again in the guidelines, Professor Ayman, they still state that you don't need to routinely test for non-HLA antibody.
There is no clinical validated test to do it.
Yes,
there is there is no clinical validated test to do the non-HLA antibodies, and there is over few thousand of them, because
Yes,
every
a
single
lot of
antigen
them.
in
Yeah,
your body
yeah.
is considered non-HLA.
Yes, yeah, yeah.
That's right.
We have
That's right.
we have some questions in the chat, Professor Ayman and Professor Ahmed.
Okay.
Dr. Asma Khudr says that if asking about blood transfusion during the operation of transplantation, does this increase the risk of sensitization? And she is asking if the donor is the mother and there is 3 mm including DR.
Hello, Dr. Yasser.
Yes. As if the donor is the mother and there is 3 mm including DR, does he need desensitization? Two questions, one about the blood transfusion in the transplant operation, and is asking about risk of desensitization and the desensitization in a case of a mother donor, there is 3 mismatch including DR, and if this needs desensitization.
I'll answer the second question first.
Yes.
And again, I'll يعني just postpone the full answer till the next lecture, inshallah. But the short answer is the mismatch has nothing to do with the desensitization protocol. The mismatch is just to estimate the risk of the potential, although this is questionable, the potential add-on immune risk for rejection. But you don't do desensitization based on the mismatch. You do desensitization based on the presence of preformed donor-specific antibodies and not any PRA level, donor-specific antibody. So a mismatch is something and the donor-specific antibody is another thing. Maybe the question would be, if the mother with a mismatch of 3, would you give induction or not? And which type of induction? Would you give a depleting or a non-depleting way of induction, like a basiliximab versus a thymo, for example? This would be the question, and I would postpone this to the next answer. But generally speaking, in a mother with 3 mismatch, I would be reluctant to give thymo. I would only give basiliximab, and if I won't be able to give the basiliximab like what we're having nowadays in Egypt because of the problem in the importation and the water for injection. So I would go ahead and start to transplant these patients without induction. Just a prior induction for a week or so by the full triple therapy, by the MMF, the tacrolimus, and the steroid, and then go ahead, give 3 doses of pulse methylprednisolone, 250 or 500 milligram per day, and go and transplant, inshallah, would go good, inshallah. Regarding the blood transfusion intraoperatively during the transplant, I'd like to do that after the declamping, not before the declamping. Although it would be of major difference and you won't have the chance to form an antibody in a matter of a couple of hours that would be performed and reacted to the graft, but you don't like to have a sensitizing effect. For example, a patient might have a reaction like what had happened with any blood transfusion at any time, even with a full match transfusion. You might have a reaction to the blood. You don't like to have this reaction before declamping of the graft. So if you can do it, of course, if it's life-saving, you would do it. If it's not, I would like to postpone till the declamping and the issuing of urine, and then you can transfuse the blood. I don't know what's Professor Ayman's opinion about that.
I need to emphasize something about the indication of desensitization. As you mentioned, it is not indicated for the degree of mismatch, and also
Yes.
it is not for the presence of DSA. The indication is the cross match. If we have a positive cross match, we should desensitize. And the aim of desensitization is to convert the cross match from positive to negative. I'm not going to perform desensitization for DSA only in the presence of negative cross-match, whether by the CDC or the flow. So
it should be it should be
target
positive
of
for Ayman يعني.
desensitization, yes. Sometimes we have DSA without positive cross-match. يعني I
والله
think
يبقى ال DSA is very minimal level يعني I think
يعني I mean
if it
we
is
should
significant channel shift it would cause a positive cross match in most of the cases.
يعني I think we should emphasize that the goal of desensitization is to have a negative cross match rather than decreasing the level of the antibody or the DSA.
Okay, thank you. Last comment.
And about the blood transfusion, I would like to hear the point of blood transfusion from Professor Ayman. What's your
transfusion?
policy?
No, we don't. This is an old practice to give a blood transfusion during the operation. I mean, she mean our colleague who asked the question that it was given as emergency bleeding, or they are intended to give blood transfusion prior or during surgery.
I think for a low hemoglobin, not for the previous notion of giving the blood transfusion.
I think if we are obliged to give, we give through a leukocyte filter, and we are obliged to give it, and no other alternative. I mean, if we have to do it, we should do it. I mean, yeah. So
but
we
would you
didn't realize actually any decent.
I mean,
I prefer
would you
follow
prefer to have it after
yes,
the
the
clamping?
DSA post transplant. Excuse me.
Okay. Okay.
I mean, after the clamping or before the clamping?
It doesn't matter. It doesn't matter before the clamping, but I think we should follow up post transplant the DSA, and to intervene accordingly, either potentiation of our immune suppression or to do any histology if there is any graft impairment. Otherwise, we are doing it. It's a common practice to have intraoperative blood transfusion due to bleeding and low hemoglobin, as you said.
Okay, Professor Ayman, last comment. Professor Ahmed, Professor Ahmed Mustafa is thanking you for this very interesting lecture. And last comment from Professor Saeed Khamis. Professor Saeed, can you hear us?
Yes, Professor Yasser, thank you. Professor Yasser, thank you. Professor Elkeraie, Professor Ayman, and Professor Ahmed. Regarding Professor Elkeraie, as we know that you are pioneer and superb in the subspecialties in all nephrology domains, and especially the genetics. My question regarding the kidney transplantation in primary or congenital immunodeficiency syndromes. Do we need all the immunologic workup in such cases, and all these the existence of these primary immunodeficiency syndrome can mitigate the need for some immunologic studies? And thank you so much.
Thanks, Professor Saeed. والله يعني you gathered the complexity all together يعني. I'm not aware إنه ال primary immune deficiency syndromes do survive to have renal failure. يعني but if this happens, are we speaking about complement deficiencies like the inherited complement deficiencies مثلا C1q deficiency, C1 esterase بتاع الانجيوإديما and so on. So even if it is so, in those peculiar states where they already have progressed to be in a renal failure state, yes, it would be very difficult decision whether or not to proceed from. Of course, I would do the full immune battery, because you don't know in this dysregulated immune system what is active and what is not active.
Yeah.
And as you know, the immune system is a multitude of effectors between the antibody, the complement mediated, and the direct cytotoxic, and the T regulatory, and the T helper, and many other. And the balance between these cells is not even totally understood for us.
Yeah.
So to be on the careful side, I would do the full immune battery beforehand of the transplantation. But the real tough and hard question, are you going to immune suppress them like the normal person or not?
That's another question. Yeah.
This is the real tough question. It's a very complex scenario.
Yes. Thank you so much.
Allah يبارك فيك.
Thank you, Professor Ahmed, and thank you, Professor Ayman. And we reached our end of this very nice journey, the first part of our journey in immunobiology of transplantation. So please, Professor Ayman, can you close the session?
Again and again, I would like to thank Professor Ahmed Elkeraie for this very smart and elegant presentation, and Professor Yasser for choosing this very important topic. And see you, inshallah, in the second part after 2 weeks, the 15th of November. Professor Elkeraie is going to address the most important issue of this part about the antibody detection and different methods of BRA and DSA and cross-match, etc. So see you after 2 weeks.
Thank you very much. Thank you, and thank you again, Professor Ahmed Elkeraie, for this very interesting lecture.
Thanks, Professor Ayman. Thank you.
Thank you very much. Thank you.
جزاكم الله خير إن شاء الله. السلام عليكم ورحمة الله وبركاته.
Thank you, Professor Ahmed, and for this and for responding to all questions and for this very nice discussion. And thank you all professors who shared, and thank you all attendees for sharing this session and interaction and interacting with the speakers and the moderators and enriching this session with your discussions. Excuse me to close this session and meet you coming Wednesday in the same time, 9 p.m. inshallah. تصبحوا على خير.
إن شاء الله.
السلام عليكم ورحمة الله.
وعليكم
عليكم السلام ورحمة الله.
شكرا جزيلا.